It's my pleasure and my honor to present one of the landmarks in the field of cardiothoracic anesthesia in Egypt. Today we have Dr. Maged Salah. He's a professor of anesthesia and intensive care, Cairo University, and also he's the Secretary General of the Egyptian Society of Cardiothoracic Anesthesia. Dr. Maged, if you'd like to start.
I would like to thank you all for your support, and especially Dr. Saad Mahdi and Dr. Walid Aswa for their support with our neuroanesthesia scientific meeting tomorrow. I'm happy to be again with Mega Online course. My presentation today is about basics of Doppler and hemodynamic measurements using the transoesophageal echocardiography. I'm going to discuss why we are using the transoesophageal echocardiography as a hemodynamic monitor. And how transoesophageal echocardiography can be used for hemodynamic measurements. The basics, of course, and I will leave you to define the difference between transoesophageal echocardiography and other methods. Why transoesophageal echocardiography for hemodynamic assessment? The gold standard for hemodynamic assessment in patients and critically ill patients is transthoracic echocardiography. It is less invasive than transoesophageal, and data obtained by transoesophageal can be mostly obtained by transthoracic echocardiography. However, in cardiac surgery and during anesthesia and during thoracic and major abdominal surgery, it will be difficult to have transthoracic echocardiography. So transoesophageal echocardiography can do this role. However, if I couldn't do it with transthoracic, it is better to be done with transthoracic. Both transthoracic and transoesophageal offer bedside real-time imaging of the heart. They measure blood flow and tissue velocities. They are able to evaluate the triad of preload and afterload and global cardiac function, with whether systolic or diastolic. So this makes it a unique method of monitoring of the patient and diagnosing hypovolemia and hypocontractility and other pathologies. We'll start with the Doppler principles, and of course we all know that Christian Doppler in 18th century defined the Doppler basics. And he stated that the velocity of a moving object, in our situation, it is moving red blood cells, is proportional to the shift in reflected frequency of optical wave of non-frequency, and this applies to sound waves. So, for simply, if I have a vehicle moving toward me, I will have increase in the pitch of the moving vehicle. Due to increased frequency, and if I'm behind the vehicle, I will have a decreased frequency and decreased sound pitch. So if I have moving red blood cells inside a blood vessel, and if I have an transmitted sound with special frequency that hits the moving red blood cells, there will be a reflected sound with reflected frequencies that can be interpreted. The difference between the reflected and the transmitted frequency is the Doppler frequency shift, and it is the basis of our Doppler measurements. And by analysis of this Doppler shift, we can define and detect the velocity of red blood cells, of the velocity of blood inside the heart and inside blood vessels. We have the pulsed wave Doppler and the continuous wave Doppler and the color Doppler. What is the difference between them? In pulsed wave Doppler, I'm using a single crystal of transducer as an emitter and a receiver of the ultrasound. For this crystal, it emits ultrasound to a specific location defined by this circle or ball, and waits the reflected sound to come from this specific situation to be interpreted. So I have a single crystal emitting waiting, having a specific location, and receiving ultrasound and analyzing it. The rate of emitting sound is known as the pulse repetition frequency. Pulse repetition frequency is the rate at which the device repeatedly generates sound burst. Nyquist limit is the maximal frequency that can be accurately measured by pulsed wave Doppler. Nyquist limit equal half of the pulse repetition frequency. So we have ultrasound that goes and to a specific location, and the transducer waits until the reflected ultrasound return and analyze the frequency shift to detect the velocity of blood at this specific location of the heart or the blood vessels. What will happen if the Nyquist limit exceeds what it will have if we have a Doppler frequency or frequency exceeding the Nyquist limit? A phenomenon called aliasing will occur. Here is a pulsed wave Doppler with below the Nyquist limit within the range of the pulse repetition frequency. So we have a well-defined pulsed wave Doppler contour. And here we have a higher frequency. So we have aliasing, شوشرة, wraparound phenomena if I exceed the Nyquist limit. Let us go to the second modality of the Doppler, the continuous wave Doppler. Two crystals in the transducer, one continuously emitting and one continuously receiving reflected ultrasound. So it can be used to measure high velocities in excess of 7 meters per second. But the problem, it cannot determine the specific location of this velocity. It detects the velocity along the whole line of emission and receiving Doppler signals. So what is the difference between the pulsed wave versus the continuous wave? In the pulsed wave, we have this circle or arrows that define the specific location where I measure the velocity. It's on the scale, it appears like white line encircling the curve, and the white dots. What these white dots represent? It represents Doppler beams hitting the blood cells and returning to the transducer to be presented as white dots. The direction of blood flow is the relation to the baseline or the relation to the zero. So here's the blood flow is away from the transducer because it is in the negative side of the scale. For the continuous wave Doppler, we don't have the specific location. So what we can see it is ultrasound or Doppler beams hitting blood cells and returning to the transducers to be analyzed. And as the jet frequency increases and as the jet volume increases, the density of this scale will appear, and it becomes more white and more dense and more clear. And every dot in here represents a Doppler line hitting blood cells and returning to the transducer to be analyzed. Again, pulsed wave Doppler is suitable for low velocity because we have a limit, which is the Nyquist limit, above which I cannot have a measurement. So it's suitable for low velocity measurement at a particular location inside the heart, suitable for LVOT, for the VT to measure the velocity, and for detecting diastolic function, diastolic thinning, to detect the mitral inflow assessment, hepatic vein velocity. Areas with low velocity. However, the continuous wave Doppler is very suitable to measure peak velocities, especially gradients across intracardiac orifices. If pathological, it will be more specific. We can have the peak velocity, we can have valvular pressure gradient, pressure half time, and gradients across the LVOT and pulmonary artery pressure. So pulsed wave for precise location, low velocity, continuous wave for high velocity with no precise location. For an accurate Doppler measurement, we should fulfill the criteria. The most important of them is to have a Doppler angle less than 20 degrees. So I should have a Doppler line as much as possible parallel to the blood flow. If I have a Doppler line parallel to the blood flow, I will have a better curve and a better and avoid underestimation of the readings of velocity and pressure gradients. Also, I should look for laminar flow and uniform flow velocity profile. We discussed the pulsed wave and the color and the continuous wave Doppler. Let us go to the third type, the color flow Doppler. In color flow Doppler, we combine information of the Doppler shift plus the 2D image. So here we have a 2D image of the heart, two-chamber view. Then we have left atrium, left ventricle, and the mitral valve. We have the velocity is not expressed like a curve with a baseline and zero line, and above the curve is the velocity towards the transducer, and below the curve, below the baseline, it is away from the transducer. No, it's expressed in the form of color. So I have a color scale. I have blue color related to movement from away from the transducer. So this blue flow indicates I have pulsed wave Doppler applied to the blood in this area inside this sector. The blue color is blood moving away from transducer. The red color here is a blood moving toward the transducer at the apex. Then I have the mosaic, the greenish color, which is accelerated blood flow exceeding a Nyquist limit. So it appears like aliasing in the curve and appears like mosaic or green color inside the color Doppler. So color denote direction and denote velocity. Blue and red are normal. Green or mosaic are high velocity exceeding the Nyquist limit. Blue is away from the transducer, red is towards the transducer. So it's a combination of 2D image and pulsed wave Doppler. As the velocity increase, the density of the color increase. So I can define something like this. I said it before. This mosaic means increased velocity, and it is in grades as we are going to see it now. And this blue and red is within the velocity range. Let us go to the hemodynamic principles, or calculations, or physical calculations that determine our hemodynamic measurements. First one of them is flow equals cross-section area times the VTI. Flow, if we have a pipe with flow of water inside it, and I decided to calculate the flow of water inside it, I will calculate the cross-sectional area of the pipe. Then I will calculate the velocity of water in the pipe. Cross-sectional area times velocity will be the volume passing across this pipe. But this is nice, but it's not suitable for the human body, because blood velocity during the cardiac cycle is not uniform. It starts slow and increase to a peak and then decrease. So velocity inside the human body is replaced by what we can call it the VTI, velocity time integral. We call it the stroke distance. The definition is the average distance a blood cell is ejected during one cardiac cycle. So it is a distance in centimeter that express the average distance one blood cell is ejected during cardiac cycle. So when I speak about human body and flow across any orifice, it equals cross-section area times velocity time integral. The second equation is the continuity equation. The flow across the aortic, the mitral valve, it finally will goes across the aortic valve. So we can say that the area and velocity across the mitral valve will equal the area and velocity across the aortic valve. and this will help many calculations, noting that there is nothing called velocity in our measurement. We use it VTI. For example, if we have measured the if we to apply the aortic to the continuity equation to the LVOT and the aortic valve, flow across the left ventricular outflow tract will finally go through the aortic valve. If I know the diameter of the LVOT, which is, for example, 1.9 centimeter, I can calculate the area of this circle by the equation. It equals by r squared. So I can get the area of the LVOT. And if I can measure VTI and across the aortic valve and outflow tract using pulsed and continuous wave. Here is pulsed wave Doppler, and here is continuous wave Doppler. So I have the VTI in the LVOT and the aorta. Then I can calculate the aortic valve area. It's a method of calculating the aortic valve area through the continuity equation. So first equation, flow equal cross-section area times VTI. Second equation, continuity equation, A1 V1 equal A2 V2, or A1 times VTI1 equal A2 times VTI2. And we had an example of what is useful of this. Regarding the color Doppler, and very important aspect of our calculation, here is an example of PISA, the proximal isovelocity surface area. What does it mean? If I'm having a flow of blood inside the left ventricle, it is red in color Doppler. It means it goes towards the transducer. So this is flow going to the left ventricle outflow tract. Then this flow across the left ventricle outflow tract finds in its pathway an orifice causing mitral regurgitation. So what happens is acceleration of the blood. Then at certain point, it takes a hemisphere shape, and acceleration starts to change the color of the blood Doppler flow, and it gets lighter at a higher velocity. Then it takes the shape of hemisphere called PISA, proximal isovelocity surface area. Then it finally passes through the orifice with the mosaic appearance, which means that it exceeded the Nyquist limit. The diameter of this PISA is diagnostic of severity of mitral regurg. However, we can use the PISA diameter and the PISA velocity and the velocity of the regurgent jet to calculate the orifice, mitral regurg orifice area through the continuity equation. Again, we had the flow equals cross-section area times VTI. The second one is the continuity equation. The third one, we all know it, is called the Bernoulli equation. Delta pressure equal 4 V2 to the power of 2 minus V1 to the power of 2. And usually the velocity of blood started with the isometric contraction phase, where we increase pressure without movement, so it can V1 can be considered 0. So delta pressure equal 4 velocity 2 to the power of 2. So if I applied a continuous wave Doppler across the aortic valve in this view, and I can have a scale, Doppler scale, continuous wave Doppler scale of the flow across the LVOT aortic valve. LVOT is the smaller one, and aortic valve is the bigger one. At the peak here, we can have the peak velocity, and the peak here we can the peak velocity. Then by using this Bernoulli equation, I can change peak velocity into peak pressure, or pressure gradient. Regarding that V1 is equal 0. So Bernoulli equation can give us pressure gradient across orifices in the heart. In this situation, give it across the aortic valve by delta pressure equal 4 velocity of 2 to the power of 2. The same can apply to the tricuspid valve. I have a tricuspid regurg applying continuous wave Doppler across it. I can get peak velocity and mean velocity. By applying Bernoulli equation, I can have peak gradient and mean gradient across the tricuspid valve. However, this Bernoulli equation is not accurate in anemia, which is common after cardiac bypass, polythysemia due to hyperviscosity, hyperdynamic heart conditions, septic patients, subaortic obstruction, and the dysfunctional prosthetic valves. So again, our three rules, we depend mostly on hemodynamic measurements related to the heart, are flow equals cross-section area times VTI, continuity equation A1V1 equal A2V2, and the third is the Bernoulli equation, which changes velocity into pressure gradient, delta pressure equal 4, velocity 2 to the power of 2 minus velocity 1 to the power of 2. And we all know that the baseline velocity in the heart is 0, so we can consider delta pressure equal 4, velocity 2 to the power of 2. What about actual hemodynamic assessment of the heart? We can detect the preload and the contractility. For preload, we can have the qualitative analysis through the transgastric short axis view. We can see kissing papillary muscles, and it denotes this heart is hypovolemic. Or we can see distended ventricle, which denotes is hypervolemic, or the direction of the interatrial septum. However, this is suitable for clinical practice, but not suitable for documentation or measurements or precise decision making. So we have measurements, quantitative analysis by the area and the volume and the diameter, and the pressure also we can detect it. We can measure the left ventricular diastolic area, left ventricular systolic area, and we can have a monitor of fractional area change equal left ventricular diastolic area minus left ventricle systolic area over left ventricle diastolic area. And there is a software, I didn't see this software a lot, once or twice, but it continuously traces the endocardial border in systole and diastole and give you continuous estimation of the end diastolic area and end systolic area and fractional area change. Normally, fractional area change is 50 to 65, and we can add an afterload corrected fractional area change to be more load independent. We have a major problem in our cardiac measurements or cardiac indices of function that all are load dependent. So we have the fractional area change, and we can measure the end diastolic area and end systolic area to detect the volume. However, cannot be used alone. We have inter-individual variations. Not all the hearts are the same. Some hearts are bigger, some hearts are smaller, and it's affected by vasopressors and dilators. So vasopressors will increase the diastolic area, and dilators will decrease the diastolic area. So will affect our measurements. The second thing is not the area, is the diameter. We can apply M mode, which is a cross section across the heart, to measure the end diastolic diameter and end systolic diameter, and apply software to change this diameter into a volume. We will see it now and how we can get it. So M mode can help us to measure the diameter. We have here the end systolic diameter, and we have here the end diastolic diameter. And through an equation called Tickle's equation, we can change this diameter into a volume. So I have corrected end diastolic volume and end systolic volume, and through it I can apply the formula: cardiac output equals stroke volume times heart rate. Stroke volume equal end diastolic volume and end systolic minus end systolic. This by measuring the cardiac output by M mode, I have a 75% correlation with thermodilution, and thermodilution is our gold standard for measuring cardiac output. So we have cardiac output. We have measured the area in the systole and in diastole, and have a monitored fractional area change. Then we measured the diameters, and we had the end diastolic volume and end systolic volume through getting diameters and M mode. And we started to measure cardiac output using first the M mode. Our rule is cardiac output equals stroke volume times heart rate. And stroke volume can be calculated by measuring end diastolic volume and systolic volume, like we spoke about, and with M mode cardiac output measurement by echo coincides with thermodilution in 75% of cases. We can use the 2D picture for measurement of cardiac end diastolic volume and systolic volume. We have most commonly used method, and this is the most commonly used method nowadays, is the Simpson method. And the Simpson method for measurement of end diastolic volume and systolic volume coincides with thermodilution in 85% of cases. Simply, Simpson method, it divides the heart into 20 cylinders by a software where I trace the endocardial border at two views, a 4-chamber view and a 2-chamber view at end diastole and end systole. So I have an estimate of end diastolic volume and end systolic volume more accurate than measurement by the M mode, and not using a formula for the transformation of end diastolic diameter into end diastolic volume. Now I have the end diastolic volume and systolic volume, and I can measure stroke volume and get the cardiac output. The third method of measuring cardiac output through echo Doppler is using the Doppler measurement. We set the flow equal cross-section area by the times the VTI. Stroke volume is the flow. So I need to measure cross-sectional area of any orifice with the VTI across this orifice. The most suitable is the aortic valve, then the LVOT, then RVOT, then mitral valve and tricuspid valve. This is because aortic valve is more uniform and easy measured. The next will be LVOT, which have this near criteria. So I have a problem of measuring an orifice area, or then the second problem is the measuring the VTI across this orifice. Well, I can measure the orifice area by planimetry, and it was found that planimetry, which is tracing the borders of the orifice, tracing the triangular aortic valve in mid-systole rather than the circular valve in late systole, coincides with thermodilution results. So I get the aortic valve and I trace the opening of this valve while it is triangular, and I will have a surface area of this aortic valve opening. The second method of getting the aortic valve area, we discussed it before, the continuity equation, by knowing the aortic valve area and through knowing the LVOT area and VTI of the aortic valve and left ventricular outflow tract, by knowing VTI across the aortic valve by Doppler and across the LVOT by Doppler, and by measuring the left ventricular outflow tract diameter, I can get its area. I can calculate the aortic valve area as we showed before, but this is less accurate than planimetry of the aortic valve. So I have detected the valve area by planimetry or continuity equation. I have the cross-section area. Then I want to VTI. VTI is suitable through the deep transgastric or mid-papillary transgastric view. I take the average of 3 cycles. Flow should be laminar, uniform, and Doppler angle less than 20 degrees, as we discussed. Why the deep transgastric especially, or the transgastric mid-papillary? Because the blood flow across the aortic valve will be parallel to the Doppler beam, and this makes a special importance of the deep transgastric view and the transgastric mid-papillary view. The two views solve the problem of unable to make a parallel blood flow parallel to the Doppler line emitted from the transducer. So if I'm going to measure stroke volume through the aortic valve, I will get the triangular valve and trace it to have a planimetry, to have an area of the valve like is shown here, is 2.5. Then I will apply the Doppler line across the aortic valve to have the VTI. I will have the average of 3 cycles then we will have VTI, cross-sectional area times VTI equals stroke volumes times heart rate equal cardiac output. So I have an estimate of cardiac output. So we rapidly discussed hemodynamic measurements. We discussed first Doppler principles. Then we discussed the three main calculations, or three main formula for hemodynamic calculation. Then we have discussed how to use endodiastolic diameter to detect the function and to detect the cardiac output, how to use the area to detect the function, how to detect, to measure the volume, and to use the volume to detect the function, either ejection fraction or cardiac output. We discussed fractional area change, which is end-diastolic area minus in-systolic area over end-diastolic area. We discussed fractional shortening, which is end-diastolic diameter minus in-systolic over end-diastolic, measured by M mode. We discussed ejection fraction that can be extrapolated for or predicted from the fractional shortening by Tickle's equation, or directly measured by Simpson rule, end-diastolic volume minus in-systolic volume over end-diastolic. We know now how to measure stroke volume with the echo and cardiac output with the echo. Finally, I want to remind you with the three major laws or equations. We use it for any hemodynamic calculations with echo. Flow equal cross-section area times VTI. Continuity equation A1 V1 equal A2 V2. And remember, its velocity in the heart is VTI, not regular velocity. And the VTI is the average distance a blood cell is ejected during one cardiac cycle. And it is VTI, but velocity time integral, but it is measured in centimeter. The third equation is the Bernoulli equation, delta pressure equal 4 velocity to the power of 2. And thank you for hearing me, and it's a pleasure to present this presentation. Thank you.
Prof. Magid, thank you very much for that excellent presentation. I will give the floor to Dr. Ahmed Abdulati. Dr. Ahmed.
Yes. So I have a question here from Mohammed Khamis. Is saying about the viscosity and what are the effects of the hemodilution cases with the Doppler. It's a big question, but that's the way it's asking.
Okay. Can you hear me?
Yeah, I hear you.
Yes. If I'm going to hemodilute the patient, like in situation when I'm having a cardiopulmonary bypass and I started to measure pressure gradient across orifices, mitral valve or aortic valve. Usually when I get off the cardiopulmonary bypass, I do not give any measurements until I correct hemodilution and I correct hyperkinetic circulation, because both of hemodilution and hyperkinetic circulation will cause the overflow of volume across the orifices. Then this will result in overestimated measurements. So if I have an aortic valve replacement, if I'm measuring gradient across the aortic valve, I will have a peak gradient of 50 or 60 if I'm anemic, or if I am hyperdynamic, which can be reduced to 30 or 40 as a peak gradient when I overcome this hemodilution and hyperkinetic circulation. So I should avoid or correct anemia before I give a hemodynamic measurement. I should correct the hemodynamic hyperkinetic circulation or hyperdynamic circulation, and mostly anemia cause it and inotropes cause it. So I should control those two factors before I give a peak or mean gradient across the mitral or aortic or tricuspid valve. If I have any of these factors, I will have overestimated pressure gradient. I will have a higher pressure gradient that will decrease. So what I do usually, if I find that the repair or the replacement is fine, I'm sure I make sure that when getting off the bypass, for example, I have a good hemoglobin level. Then I wait for a few 10 or 15 minutes to give the final pressure gradient across the valve. And at the end of the operation, my final pressure gradient is mostly I can get the final pressure gradient at the end of the operation. Early post bypass period, I will have a hyper overestimation of the pressure gradient, and however I can predict this overestimated pressure will decrease or not according to the shape of the repair or shape of the replacement and the size of the valves.
I have another question from Anas El-Shimi. He's saying in anemia and polycythemia, the Doppler readings will be underestimated or overestimated?
Anemia will be overestimated and polycythemia it will be underestimated.
Thanks very much, Dr. Magid, for this nice presentation. And this was the last question.
Thank you.
Thank you.